I'm Professor Dr. Vivek Gupta. Today I have a very special day because I'm sitting with one of my friend, a good friend from UK, United Kingdom, London, Dr. Bernard Prendergast, who is one of the very eminent or renowned cardiologists from United Kingdom. Today we are in Chennai and I have the privilege to talk to him regarding we will talk only basically on TAVI, which is Transcatheter Aortic Valve Implantation. And that means non-surgically deploying another valve in a diseased aortic valve. Aortic stenosis is a very serious disease. Before I will just introduce Dr. Bernard is working in a Cleveland clinic in London, and also he is associated with a very important St. Thomas Hospital, which is a teaching hospital.
Correct.
In London. And we will initially, after introduction, I will introduce a topic, and then he will have his own words. He's one of the very important cardiologists, having a great knowledge, in-depth knowledge of this procedure, which was initially done for the first time by my mentor and personal friend, Dr. Professor Alan Kribbier, and that was 16th April 2002. I had the privilege to work with him in 1996, 97, 98, and after that, I was so well associated with him that he became a personal friend. He came to my home in Delhi, and also we met. He used to, he was a person who used to pull out his heart. Heart means he will talk about his family, his things. We were very closely friends. Unfortunately, he is no more. We lost him recently, but he is in our minds and all. He did the first in man transcatheter aortic valve implantation. Now, since then, 2002, which is more than 20 years, we celebrated 10 years and then 20 years of TAVI. I think you were there in Rouen, in Charles Nicolle Hospital in France, when 20 years of TAVI was celebrated in 2022, just after EuroPCR. So now, after Dr. Kribbier no more, he's almost going to the shoes of Dr. Alan Kribbier, although he will be doing some more innovation later on. So today, my discussion will be aortic stenosis. That means stenosis of the valve, aortic valve, which is the main supply to the whole of the body. It is one of the important, out of 4 cardiac valves, aortic valve is the most important, and any blocking or stenosis means narrowing of the valve leads to serious implications and sometimes sudden death. And with the aging population, it is getting more and more common. And the earlier surgical valve replacement was the common thing, but many patients earlier was not been able to be operated because of other comorbidities, and that is why this technology was evolved by Dr. Kribbier. I want to know, Dr. Bernard, tell me a little more about yourself, because I have not completely told you. Tell me about yourself and your relationship with the valve technology.
So I've had an interest in heart valve disease since I was a doctor in training, but in those days the only option for the intervention of heart valve problems was open heart surgery. And open heart surgery for valve disease has been with us since the 1950s. And let's be clear before our enthusiasm for other technologies takes over, heart surgery saved the lives and extended the lives of many hundreds of thousands of patients. But the issue with it was that open heart surgery is a big procedure for a patient, and in many situations, particularly older patients, the opportunity for surgery was denied because of either the age of the patient or their coexisting diseases, whether it was the bad lungs, whether it was their frailty, their immobility, problems with their kidneys, for example. These would be common reasons why surgery would be excluded. And therefore, as you say, when Alain Kribbier was brave enough to undertake the first TAVI procedure after developmental work not done only by him, but also by Professor Anderson based in Denmark, the first patient was able to receive a keyhole transcatheter treatment in 2002. And the world stood back and initially thought this was a crazy idea, but as the numbers accumulated and the procedure became more refined, it became expanded to many other countries. So enter myself into the arena in 2008 when the first procedures were performed in the UK, and I was working in Oxford at that time. And
Oxford?
Yes, that's right. And Professor Banning and I undertook the first TAVI procedures together in Oxford at a period when it was growing very rapidly in the UK. And then in 2015, I was lucky enough to have the opportunity to move to work with Professor Redwood, Simon Redwood, in London, who had already established the first PCR London Valves meeting. And with a new vacancy in London, I was able to partner with him and grow the meeting even more over the subsequent years, such that London Valves is now the biggest meeting in the world dedicated to this field. And that in turn has opened up the pathway for relationships and friendships with doctors such as yourself, Vivek, in India, in Latin America, in China, in Japan, etc. And this has really become a worldwide endeavour together. And we're enjoying educating each other, learning from each other, and we're enjoying each other's friendship and partnership.
Dr. Bernard, it's a very interesting thing you told that you did the first in 2008. At that time, India did not have it. I remember the first patient from India was done by Alan Cribier, and that was in Rouen, Charles Nicolle. When I took the patient from India, flew to Rouen, Charles Nicolle Hospital in France. That was November 2011, and that patient received Edward XT valve. And then the patient lived for 9 years. He died of nephropathy recently. So in UK, I think in India we got a first in 2017. I mean, quite delayed.
Yeah.
15 was the first case done by Dr. Gopal, Indian patient in India after DCGI approval. Although the first Indian patient that I told you was done in France in November 2011. So since 2017 onwards, India has also moved rapidly by doing a lot of
very
cases.
Quickly,
So I just wanted to know, for our interest, London, because you're working there, versus India. So do you think that the same type of work are we able to do, or you feel that you are, because you started earlier, you are doing a little more serious and complicated patients? Can you see the difference between the aortic valve done here in India in so many centers and your place?
I think that the difference lies in the model. I think that it's clear to me that India has accelerated very rapidly in the last 5 years. I've been attending this meeting in Chennai for the last 5 years, and the skill and the expertise of the Indian interventional community is very, very impressive. So in terms of complexity and challenging procedures, I think the high volume operators in India have got up to speed very, very quickly. I think the difference is that in the UK we are offering a nationwide all-comers model, where of course the structure for funding and the application of the technology in such a massive population in India is more challenging. So in the UK we already have long waiting lists for the procedure, and that's because it's a procedure that's provided through the publicly funded National Health Service, whereas I understand that most procedures in India are performed in the private setting. And clearly there are many patients with valve disease who cannot afford to have a procedure performed privately. So I think that there's a lot of work to be done in the penetration of the technique in India, but there's no question that the expertise and the skills of the doctors are matching those in Europe and the US.
Oh, that's a very heartening comment from your side, that expertise is almost the same. But it's unfortunate that you have a huge waiting list to the patients who are sick enough to be actually given the TAVI or tower, what Americans call it. So what do you do with those patients? Do they have the opportunity to be operated in a private setup in the UK, or they have to really wait?
Well, they have to wait, and if they become ill, they get admitted to hospital. Of course, they're not in such good shape to have the procedure, and that means that the procedure carries more risk. So this is a problem for the service that we're delivering. In fact, we're working in partnership between the NHS and Cleveland Clinic in London to provide more capacity to allow NHS patients to be treated at NHS cost in a private hospital. That's a new partnership that we've developed with St Thomas's, and Professor Redwood brings a large volume of his procedures and performs them in the private hospital, essentially free of cost for the health service. It's the same tariff as they would pay in the public sector.
That means they pay individually and they can get the procedure done.
No, the NHS service is using the Cleveland Clinic resources. So effectively, it's being done at NHS price, and that the patient pays zero because it's an NHS
But if somebody
procedure.
wants to pay,
if they want to pay,
they're allowed to pay?
Then that can also be done. But as you know, TAVI itself is quite an expensive procedure.
Yeah, it's much more expensive than India.
It's beyond the budget of many patients. So in the UK, it costs approximately £60,000, which is around 80 or 90,000 US dollars. So it's a lot of money.
It's about 80 lakhs rupees, Indian rupees, almost touching 1 crore. It's a huge money. Yes,
it's a lot of money.
So we are able to do in 20 lakhs, is 25 lakhs That means something like 20,000 US dollars, 25,000.
Yeah. So there is a budgetary question, and I think there is an important demand for the price of the procedure and the price of the device to become cheaper, so that it can be applied in more and more patients worldwide.
This is what happened with the coronary stent. Earlier it was quite expensive. Okay, coming to the last or second last question, you have to take a flight. I wanted to know that those patients of aortic valve stenosis, there are two types of valve which are, one is balloon expandable in general and other is self-expandable. What Dr. Krieber devised was a balloon expandable valve, and then earlier it was known as Krieber Edwards valve, and then it was finally Edwards XT and then Edwards Sapien 3. You know all those things. So the balloon expandable versus self-expanding. If somebody wants to learn a new, I'm talking of the young cardiologists are there, should they get trained for the self-expanding or balloon expandable? I personally feel, which I may be wrong, that balloon expandable learning is easier than self-expanding. What is your take on that?
So over the years, and I don't do so many TAVI procedures myself now because I'm getting old and I've been in the field a long time.
You are still younger.
I'm getting older. But the majority of the procedures that I have learnt have been balloon expandable. And I think that is the easier technique to learn. But I think for the next generation entering the field, they need to be able to use a wider range of devices, because we've learnt that adapting the choice of the device to any individual patient's anatomy is very, very important to achieve the best outcomes. So I don't think in the modern era you can afford to be a single valve operator. You need to have expertise in a number of devices.
But first learning should be balloon expandable, this is what?
Well, not necessarily. I think it might depend on your mentor, it might depend on the centre where you are working.
And both are giving equally good results, or?
Both are giving good results, but I think we now know that with the CT scan and the clinical judgments that we need to make, that we need to adapt the choice of the valve to the individual patient, and therefore a selection is important.
I want to have a very specific question. There are a lot of patients coming to us in Apollo, and they are young patients. And now a lot of people are getting aware of this technique. You know, we are using a bioprosthetic valve, which has a limited life of about 10, 15, 20 years, 10, 15 years, I would say. And as of now, we are not offering this valve because you can do a surgical aortic valve replacement. I'm talking of a low-risk patient where surgical it is possible, but if the patient wants at the age of 35, 36, 38, 40, would you be able to go beyond the guidelines, or would you really ask him to be operated? It's a very specific question.
It's a very specific question. I think in the UK, we would not usually, it would be quite an unusual situation where we would use TAVI in a patient in their 30s or 40s, or even in their early 50s. We would do that if they had other conditions that meant that surgery was impossible. But that said, the indications are creeping downwards all the time. The age threshold is getting lower and lower. We have very good data from all the studies in younger and lower risk patients showing that the valve procedure is safe. But we need to have a little bit more information about the durability to know that these devices will last 10 years or longer before we really go wholesale into the younger population.
But not only that, I personally feel the way technology is advancing, after 10 years you never know, you can do another valve on the same patient.
So you can do a valve in valve for sure, a so-called TAV in TAV, and we're learning about that, and we're learning how that technique is best applied. Very careful selection and very careful techniques. But you're right, we cannot predict the future. In 10 years' time, everything will be different. And this is a very rapidly moving field.
And for 10 years at least, this TAVI will be working. We know the longevity of bioprosthetic valve. So I think if somebody is really serious and interested, we should not deny him.
No, and I think we are now in the position where patient choice and shared decision-making is key.
Is the key. Okay, so the last question would be that what do you think the future? I mean, the surgical aortic valve replacement will be actually gone, or it will be really be, after 5 years? Because nobody can, as you said, cannot predict the future. But I think so. The surgeons are also learning this technique, and they would like to do TAVI themselves or TAVI technique themselves. What do you think? The surgical will be much and much less, or it will go away completely? Or there will be still few patients who will require the surgical aortic valve replacement?
I predict that about 90% of aortic valve procedures will be done percutaneously or transcatheter. So TAVI will be applicable for 9 out of 10 patients. but there will be some patients for the time being where surgery remains important, and we will always need cardiac surgeons to help and support us.
Second last question again. I'm sorry, I will take a little. You take water, I think it's better. A pure aortic leak, aortic regurgitation is reasonably common. And they don't have enough calcium, and they are the patients basically of rheumatic heart disease. Earlier they were not choice at all. Now I think the few devices which have come, where we can do TAVI in a pure severe aortic regurgitation with LV dysfunction. What is on take on that?
Yeah, so we've been using conventional TAVI valves for leaky valves for a number of years, off-label as we say. But now we have dedicated devices that are an improvement on the existing availability, because the anatomy is often very different. These patients have a big annulus, there's not so much calcium, so specific devices are needed to get the best results. But these are now coming down the track, and we will be using them increasingly in the coming 3 to 5 years.
The regular valve should not be the first choice. There should be dedicated valve we should use.
I think that's where we are going to land, yes.
And how they anchor, because there's no calcium.
No, they anchor to the native valve leaflets. So rather than pushing the leaflets out of the way, the devices are configured so they can clip themselves to the existing leaflets. That's the technology.
This is the new. Okay, so this I was aware, but I wanted to listen from your horse's mouth, I would say. So I think to finalize this small, interesting face-to-face with Professor, no less than Professor Brenda Bernard, Prendergast from UK, aortic valve technology is more and more, aortic valve disease is more and more coming up in degenerative, especially because of the aging population. And till now, I think more than last year data was something like 6 million patients have been operated worldwide, or 7 million.
Yeah, huge numbers.
Huge numbers have been operated all over the world. A patient is discharged almost the third day or second day, and the patient is no cut on the chest, and we will move on to further technological advancement. The cost is little prohibitive for India as well as for your place, but the cost will come down. But of course, getting his heart opened up with the chest and surgeons, which is not easy, and also this surgically risk is little high. I would say any patient, you can't say the surgical aortic valve replacement will still have, even if the normal risk patient will have 1 to 2% risk. You never know who gets trapped into that risk area.
Of course, yeah.
And this is seemingly very safe, and there is no problem. And we'll be moving, now he has a flight, and I will be meeting him again in London Valves on November 24, 25. And I don't know whether he will be able to give time, but I request him that at that time also we'll talk about what London Valves has taught us in November when I come to London.
That would be
Thank
great.
you very much for watching this video, and I just want to say, we missed out a little more about yourself, because you please tell a little more about yourself, other than what you're doing in Cleveland Clinic, how many procedures you're doing, how much busy you are there in London. During your time, just 30 seconds.
I'm always busy, so I have a big general cardiological practice. I do less interventional procedures these days, but I enjoy leading a very inspiring group of people in London. I also try and find a little bit of time for my family when it's possible, when I'm not on the road meeting Vivek and other international colleagues. But I love my job, and I shall be doing it for a number of years yet.
If your job becomes your passion, that is
then you are a lucky man.
This is what Alan Kirbier. I finished my thing with a small quote from Alan Kirbier, because I lived with him, worked with him for 2 years. One interesting thing, I was having a tea with him, or it was, I think, lunch break. So he asked a very specific question: Vivek, would you like to have a long and boring life, or a short and exciting life? I can repeat the question, very interesting question. Elaine Alshanov and myself and Alan Kirbier. So Alan Kirbier said, would you like to have a long and boring life, or a short and exciting life? So I quickly said, because I'm a little more in witty, I said I would like to have a long and exciting life.
Yeah, you
Then
want
said,
the best of both worlds.
Then he said, you're asking too much. Thank you very much, Dr. Bernard, for a very nice
Thank you, Vivek.
face-to-face. And
Good to
it's
chat
always
to you.
a learning, because when you talk, you learn.
Exactly.
When you speak, you learn. When you chair a session, you learn. So every day is learning for all of us, and this is what our Prime Minister Narendra Modi says, that he is still learning. You know our Prime Minister Narendra Modi. And yesterday only, I will show you, I wanted to meet your Prime Minister, the new one, Mr. What is the name? He's changing so many, so you forget. So I received a letter back from him, 10 Downing Street, signed by one of his representatives.
Okay.
Thank you very much for remembering me. And he wrote, I'll send it to you. But I will be trying to meet you during your London visit. I'm not sure, but please let me know when you are in London, and we'll have a small meeting, because we want to develop some Indo-UK hospitals.
Absolutely.
So your Prime Minister wrote to me. I was very happy. Only recently came on an email.
Fantastic.
Thank you very much. I think
Thank you.
we love our profession. Doctors are very busy. They're lifesavers. But if you start having passion for your profession, then only you can excel. All the young doctors, I always say that you start loving your work, because there are a lot of obstacles in getting senior. As you grow more and more, there are a lot of, not obstacles, but there are not hindrances, but there are a lot of challenges. It's a better word, challenges. So you to become successful like Alain Cribier or Dr. Bernard, I will not say still myself, but you have to work hard and do your work passionately and ethically. Most important thing, ethics. Don't try to move out of, if you try to treat your patient as if he's your family member, you will do the best. The best decision will come when you think that this patient could be my family member, then what should I do? Whether it is angioplasty or medical treatment or bypass surgery or TAVI or anything else. So I always tell all my family, or all my junior doctors, treat the patient as if they are your next family member. The decision will be the best decision in the interest of the patient. Thank you very much, Dr. Vivek Gupta from Apollo, sitting in Chennai with one of the stalwarts of valve technology and otherwise interventional cardiology, Dr. Prendergast. Thank you very much for your time, and we meet soon. Thank you.